everyone, and welcome to the second Serious Illness Community Practice webinar on workflows. My name is Francine, and we're going to be starting very shortly, but in the meantime, if you want to take our introductory poll to let us know a little bit more about yourself, that would be very helpful, and we look forward to starting soon. Good afternoon, everyone, and welcome to the second Community Practice webinar on workflows. I'm Francine, and I'll be your host for this event. Thank you all for joining us today. It's my real pleasure to introduce Drs. Rachelle Bernacki and Josh Lakin. Josh here is one of our palliative care faculty members at Ariadne Labs. In addition to being a palliative care provider, I'll move the screen for you guys. In addition to being a palliative care provider, Josh has worked on implementation of the serious illness care program in both the primary care and hospitalist settings. Rachelle is also one of our palliative care faculty members at Ariadne Labs. She's actually our associate director of the serious illness care program and has co-led our flagship study on at the Dana-Farber Cancer Institute. Really like to thank you all again for joining us, and we're really excited to discuss more about workflows. Before we jump in today, just want to go over some webinar functionality with everyone. We have put everyone's lines on mute just to cut down on background noise, but if you have any questions or comments at any point during the call, you can either type them in using the chat box on the right-hand side of your screen or use the raise the hand icon again on the right-hand side of your screen. Those are found under the raise your hand is under the participant tab, and on the sort of the bottom corner you should see a little guy raising his hand, and then the chat function is also there. You can choose to either send to all of our participants, you can send to myself as the host, or you can send to the host and the presenters. And you can also feel free to use that Q&A function if you'd like, and that will come directly to us as well. If you have any point, or if at any point you have any technical questions or concerns, again, you feel free to use that chat to host. I can answer it directly. My colleague Jim is also here to help assist us. So today's webinar objectives are really to understand workflows and why they are important. We're going to establish some workflow diagrams and then be able to share example serious illness care adapted workflows. We're also going to share a generic outpatient workflow diagram with you. So if you were able to join us, or if you've joined us on previous webinars, you've probably seen this, what we call sometimes the ribbon or the pathway. So this is our visual that we like to use when we discuss implementing the serious illness program, and we will have webinars that touch all points of the implementation journey. And where we are now, we're moving into this phase 2 planning for implementation, and one of the most important steps is thinking about how it integrates into the clinic workflow or the workflow in which you plan on implementing the program. If you were able to join us for the last webinar, or if you maybe saw it on the Community of Practice website, we really did a broad overview about building foundations, and Dr. Bill Berry, our interim director of the implementation platform, provided us that great overview. So to recap again that overview, we reviewed the roadmap overall and the different topics within. We discussed how to know whether you are ready to implement. We reviewed building an implementation team and best practices for engaging your colleagues and leadership. And we discussed techniques that make you more successful in leading either this quality improvement initiative or similar initiatives. And again, that webinar can be found on the Community of Practice website if you weren't able to make it last time. So I'm going to turn it over to Josh now, and he's going to start us in on this webinar.
Perfect. Thank you, Francine, and thank you, everybody, for joining us today. So I'm going to start off by just covering some of the basics before we jump into examples, and we're going to kind of work from the foundation of the most basic question here, which is what is a workflow, and then work through some examples that are non-medical and then medical and then serious illness care related as we go through this to kind of build upon each step of this. So the first thing from a basic standpoint is what is a workflow? So what we're talking about is really just a very clear and well-defined set of actions that have to take place in order to accomplish something, a particular task. And you can think of many examples for it. For example, a workflow for me that I sometimes don't get right, but I try every day, is to brush my teeth in the morning, for example. And there are a clear set of steps that have to happen in order for me to go from whenever getting ready, my process of getting ready for work for the day to getting my teeth brushed completely. And if I skip them, like forgetting to pick up the toothbrush or put on toothpaste onto the toothbrush, things don't go so well in terms of accomplishing cleaning my teeth, right? So what we're going to be talking about is something far more complicated than brushing your teeth, but that's the general idea. Is there's a clear set of steps that you want to try and work through in order to accomplish a task. In this case, having a conversation between a clinician and their patients about what's most important to them, their goals, priorities, fears, and worries. And so just to point out, all workflows have three basic things, and as you diagram these, I start by figuring out where it is that the workflow starts, or the beginning, and then I generally put the end, and then the hard part is kind of figuring out all the actions and decision points that go in between. So we'll dig more into that. Before we dig into it, the question is, why should we care? And why should we all care about workflows as part of this work or in general? The short answer is it will save mapping out workflows, and getting this right and taking the time to think about them will help you achieve what you want to achieve, and also make sure you don't waste time or build redundancy in the system. So the goal really is to streamline everyone in the system and what they're doing, so that people are doing their job and then you can do yours, right? So it reduces redundancies, eliminates dropped balls in the system or things that you were expecting to get done before you pick up the ball and run with it. It helps to clean up and kind of fine-tune rough processes. Every time I've drawn up a process, I think, from the get-go, it is not as I expected it. So when I draw it out, it's a little rougher than I thought it was, and it helps me to be able to clean them up. So it helps you to make it clear. And it also helps you to know what order things happen in reality, not what order you think things are happening. And so the point is that if everyone does each step of the workflow, without forgetting key steps, what you get is what you hope for. So you start and you finish with what you were hoping to get done, and the goal then is to have a more relaxed and efficient process and practice of having conversations about goals and values. So let me pause for a second. I saw in the initial poll that a lot of people had either worked in QI or had QI experience, and that there was a lot of people who had administrative and project management specialists. And so I wanted to stop and find out how many, so do you have experience yourself designing it and mapping workflows? Let's just take a minute if you wouldn't mind answering the poll on that.
Oh, we have about 15 seconds left on the poll.
All right, thank you. So it looks like it's about 50-50. So a good number of you have had experience designing and implementing workflows. A good group of you hasn't done this before, so that's perfect. I have an easy excuse because if you built one workflow, you've built one workflow. They're all very different. So, but thank you. It's good to know that some of you have experience. Please definitely weigh in as we go through this call. So let me give you a better example than my toothbrushing one, or at least more detailed one. So let's start with a non-medical workflow, right? I haven't been to McDonald's for a long time. I don't know if you still actually order by number, but this is what you used to do when I was in high school, and I would go to McDonald's way too much. And what you would do is you'd go up and you'd order a number, which generally contained a sandwich of some kind or a burger, fries, and a drink. And McDonald's, over years and years has really refined their processes to make things fast and efficient, right? So they have processes down. And so what happens when someone pushes into the computer number 5, or back in my high school would yell over their shoulder number 5, is everyone would go into motion at the same time. And so the person running the fry station would put the basket in the fryer, or if there was warm fries, they would flip them, but the person running the burgers would start cooking it, flip the patty, keep things moving it. The clerk who I was talking to would bring up the sale, grab a drink and hand it to me with ice in it to go fill. And while all this is happening, right, I was still trying to figure out if I had enough money to pay for it. So you're, as the customer, are working to find your payment. They don't need to coordinate. Everything kind of happened automatically. It was exactly the same thing every time I went in there. So everything's ready when it needs to be, and the fries are hot, your burger is hot, the ice hasn't melted in your drink, and everything kind of happens all at once. They get the outcome that they were looking for. So let's go into what I think is kind of my typical experience when I go in for my own primary care appointment, which in medical, so here's an example of a workflow in medical, or in the medical world, right? So this happens a lot when I go into different clinical offices myself. But so I go in with my wife, I check in at the front desk, I sit down. 2 minutes later, the receptionist will call me back up, say that they don't have my address on file or don't have my insurance on file. I'll provide my card and my address. Ask me to sit back down. I sit back down. They come back, call back up and said, oops, forgot to get the card. They'll get the card, make a copy of it. A couple more times I get up and I go back up there, and then I go back up and remember that I've got to schedule my next appointment, and so I go back up and do that. And it kind of goes back and forth, and intake process itself takes 3 or 4 steps before we're all ready to actually, for me to see the clinician that I'm there to see. And it kind of, in this example, and I'm doing this a bit tongue-in-cheek, I definitely have appointments where things go very smoothly like they do at McDonald's. But in this example, nothing was ready when it needed to be, right? Each step was kind of figured out independently and alone. So the way that I typically think about it, and that we typically do this, and it's an important process as part of this, is when you have a process like that, checking someone in for a primary care visit, delivering them a burger and fries, or in our situation, having a serious illness conversation, there is a tool that's really helpful as you think about doing this, which is to actually map and draw out the workflows, right? So the goal here is to kind of map and review workflow steps. So let me talk about this generically from a serious illness care program. So this is something that I would argue is a kind of starting point for a conversation. And what we've done here is put the starting point for a workflow for a conversation in an outpatient setting generically. We left off kind of the measurement piece of things here, but this is the kind of clinical steps. And so as you walk through this generically, the way to think about it is first, somebody who creates a list of patients who are at high risk of death or who have unmet communication needs and serious illness. Then a clinician of some kind reviews that list. For example, they could ask themselves the surprise question, so would I be surprised if this patient died in the next year? And then the patient is either deemed appropriate, so it goes into a diamond there where there is something that is measurable. So a patient's deemed appropriate for a conversation, or no, the clinician decides they're not appropriate, and they go back to the list of patients who might have unmet needs. But then if a patient is deemed appropriate, the next step in the process is someone's got to schedule an appointment for the conversation to happen. And from there, someone then has to notify the patient. So an info sheet goes to patient, and the pre-visit letter goes out. Next, then, someone else has to let the clinician know that the visit is going to be happening that day, so it's prioritized and they're ready the morning of the visit to have the conversation. Next, clinicians have to have a way of being triggered, so moving down to the box in the bottom right corner of the slide. The clinician then has to be cued to remember to have the conversation at that visit. The next step in the process, clinician then has a conversation and documents it in the medical record. There's another dotted box around that from a process standpoint, as this is something that can be measured. And then if they don't have the conversation, if something else come up, the patient has crushing chest pain and they have to do that and send them to the emergency room, the patient you go back up in the process standpoint, and whoever's scheduling appointments has to remember and schedule another one for next time. If the conversation does happen, then someone in the office has to give the patient the materials for the program and pass along the family communication guide. And then we move to the end of the process. So following up with a patient a couple weeks later and making sure that they're coming in for additional visits. So that was an example of a generic outpatient workflow. We're going to show you some real ones later from a couple of different places around our system where we've been implementing the serious illness care program. But let me talk a little bit about the kind of how do you build one of those and how do you use that process to kind of redesign and optimize a workflow to get from the example I gave of my experience in primary care to my experience at McDonald's, right? So from something that is clunky and where the processes are not lined up to something that feels efficient, that quickly and gets you to where you want to go. So the first thing is, and this sounds simple, but is to analyze the current workflow. Now, that doesn't mean write down in these boxes what you think should be happening. This means go in and watch what people are doing and write down and record how people actually do things. In my experience, the first time you actually map workflows, they're pretty messy, and they're often, for me, are not even close to what I thought was really happening. And so it's really helpful to actually get in and map the actual workflow. The second point of that, which is really important, is to make sure you're getting input from other people. So I usually put down that messy thing and say, did I get this right? And they're usually like, oh, no, John does this and Jim does that, and you didn't see this happens behind closed doors. So then you'll get more input. So make sure you get input on other people's roles and what you drew out. Then continue and review and finalize that. workflow. And usually in that process, you'll have, like I mentioned, kind of a complicated map of things, of how the process works. You'll already have a pretty good feeling for where waste is in the system. People have pointed that out, but these diagrams can really help you identify waste and the opportunities to fix things. Then re-engage your frontline clinicians and redesign the workflow. Test that new workflow just a time or two or maybe 3 and see how it goes. And then analyze it again and refine it if needed. So it's a pretty quick cycle. I mean, the initial assessment of it takes some time, but the revisiting of it and revising it I do pretty quickly if I can. So I kind of already covered a little bit of this, but as you think about mapping existing workflows in serious illness care specifically, I covered a couple pieces of this. We've already put together that generic workflow, so you can start off with that generic workflow if that's helpful. The other thing I mentioned is you can kind of go in and watch standard practice, but in many places where people are implementing this program, there's not a standard practice around this necessarily, so a lot of times you're building and kind of building a workflow. So start with the generic workflow so you kind of know the key steps in this process. The second is finding staff that are responsible for activities in the workflow. You're going to see this in our examples later, in the example we give in our primary care space where we have some key staff who really own this workflow process, and you'll hear that. And then engaging that staff is absolutely critical. And don't forget all the staff who are working in that space, right? The clinic managers, medical assistants, and nurses' aides are the physicians, the receptionists, administrators really pay close attention and engage everyone who's in the space. If you leave out someone key, it will really come back to bite you. And then, to the specifics of the diagram itself, I kind of touched on this with a dotted line around something, but in that workflow, generic workflow, we showed as an example just a few minutes ago. The shapes of the boxes and the dotted lines and the arrows are actually intentional. So we usually encourage using boxes for steps in the process and then switching to diamonds when there's decisions. So the examples in that workflow was the diamond decisions are points where there was kind of branch points where when the clinician reviews the list of patients to decide if someone is or is not a good candidate for a conversation. So there was a diamond there with a dotted box around it. There's also a diamond on the conversation itself. So a clinician can say, nope, this appointment is not a right time, like my example with the chest pain example where they decide they're sending the person to the ED is not a good time. So those were decision points. You get to put and then an oval to kind of indicate the end point of the workflow. And then I talked a little bit about this, but as you're working on observing and designing the processes themselves, it's helpful to assign someone to help take notes and record and edit and enter steps into this as you build the boxes and arrows on your genetic workflow, and then, as I mentioned before, getting the staff input on that process. So making sure you're involving staff, the clinic staff or the staff at the site where you're mapping the process and doing that. Yeah, and sticky notes, you had that at the very end of this line, but sticky notes are helpful because they can be squares or diamonds, right? So you can just turn a sticky note by 30 or 45 degrees and it all of a sudden becomes a diamond. So you can use sticky notes if they become decision points where you thought you had a step. So with that, let me turn it over to Rachelle, who's going to talk some more about process.
Hi, everyone. Thanks so much, Josh, for taking us through all that. So I think, as Josh alluded to, once you have your workflow, then you want to look at where can we improve. And usually it's pretty obvious, but I think taking a more formal approach can be often very helpful. So it's a good place to start is to say what's working or what's the best steps in this process, and then asking what makes those steps the best. And you know, often this is because it's really clear, there's a really clear decision. It always works the same way every time, and it's very efficient. Patients are satisfied. So sometimes it's good to start with those so that you don't get too discouraged and say, gosh, nothing's working right. So if you can find some part of your process that's working, you can highlight that, and it can give you like sort of a win to keep people engaged. And then it's usually pretty easy to see where you need improvement, and usually those places are places where sometimes you do it one way or sometimes you do it another way, or there's multiple steps where it could really be a lot more streamlined. And then, so I would say that those are the places where you can really improve it. And it's often very obvious. Sometimes, though, I would resist the sort of quest to fix everything at once. You want to try to fix the simple things and then test it out and see how it works before, saying this is our final workflow. So, and often it's good to test one thing at a time rather than doing multiple changes at once, because then sometimes you can't figure out what actually made it better. So now we're going to move on to one of our polls again, and our first question is whether you have a serious illness care workflow in place, and then the second part is whether you experienced or anticipated pain points in the program workflow, and some of those common issues, which are patient ID, following up with patients, EHR issues, and communication gaps.
We have about 30 more seconds on the poll. If you're in progress, if you just click the submit button, then it should submit your answers. All right, so the poll results should be showing in just a minute. You'll see that a lot of you, or about a quarter of you do currently have a workflow in place. And then, as expected, about a third of you have experienced or anticipate to experience some communication gaps, along with some concerns about follow-up with patients. So we would love to open it up for some discussion. Either there's like I said, a good number of you that have developed some workflows, and then so to discuss what workflows you have developed for this program, or some others, as I think it was 3/4 of you have done workflows before, and then what has worked well about those workflows. So again, you can use the raise the hand icon in the presenter tab, or you can do chat or the Q&A. I know the poll is frustrating in and of itself. I think we had a question for Josh. It says this workflow is very heavy on the surprise question. Actually says your study published in this year's Health Affairs mentioned that 80% of at-risk patients were not identified using the question in the primary care setting. My question is, how critical is the surprise question, and are we still in a research phase trying to understand the usefulness and effectiveness of the surprise question, or outside of the surprise question maybe setting?
That's a fantastic question, and I could probably talk about that for the entire rest of the time. You're right that we put in that workflow, there was essentially an example of a patient identification algorithm, which we put in as the surprise question in that workflow. As you mentioned, and we did publish this, the surprise question has had ups and downs in my experience, at least in the primary care setting. I have found that I think that it really activates clinicians to have conversations. It's something that they don't take lightly, and so answering that question gets them activated to have a conversation. At the same time, like I put in that paper, and we've also published in JAMA Internal Medicine in the primary care setting, I'm not real satisfied with the amount of false negatives it has. In other words, it misses a lot of people I think would benefit from this intervention, and this intervention is not like a prophylactic mastectomy. It's a procedure, one that has been averaging 15 to 20 minutes, this conversation, and so it's something where the false negatives for me are painful in the primary care setting. Fortunately, we'll be having a whole webinar on patient identification and selection itself. So, so I think that deferring some of that question to that time and talking, it's kind of where we have more time to talk in detail about patient identification methods will be most helpful, because we'll be able to get into more of the detail there. The short answer is the surprise question does work in some ways for this, and in other ways has provided challenges as a patient selection step.
Yeah, and that webinar actually will be coming up in January, and Josh will also be presenting there, so he'll be able to talk more about even the surprise question or just patient identification in the primary care setting, which is what the health affairs paper was geared towards.
Yeah, but the short answer is yes, we are still in a research study phase to figure out what the best identification methods are in this space. We haven't seen a perfect answer, if we've even seen a good one yet.
So if anyone else, maybe one more person wants to talk about workflows and if they've developed any either for this program or others that have worked well. So someone is asking a great question. So the question is, to set up an appointment for a serious illness conversation, is adding time for an appointment part of standard work? If so, who and how is the decision made?
So in the partners and in the Dana-Farber trials, we allowed clinicians to decide whether they wanted to add additional time to their appointment. Some people wanted to and had it set up with their administrators to do that, and other people didn't. So I do think that now with the ACP billing code, it certainly is feasible to, if you're the type of person that you know it's going to take you a certain amount of time and you want to block that time, you can bill for it. So I think it's even more feasible than when we ran our trials. I think the other thing that I noted, and someone said, you know, you asked us just to pick one pain point, and there's so many, and we absolutely see that. But most people said that there were communication gaps between the providers and the admin or management staff. And I do think that doing a workflow where you have both clinicians, nurses, front desk clerks, everyone doing the workflow together, it's an amazing tool to reduce those communication gaps. So if you haven't participated in doing this before, I think it's definitely worthwhile, and you may fix some of your problems just by going through this exercise. And I think you can start, by just starting with an hour, and you may, uncover a lot in that.
So we see that more questions are coming in. That's great. Keep them coming in. We have more time for discussions later. But we want to make sure we get you all of the presentation as well. So hand it back over to Rachelle to do those examples from the field.
Right. So, if you're implementing primary care across a region, you may have some places where you have 1 to 2 primary care clinicians in each practice, or you have the implementation has a patient evaluation component, and some, of our IRBs require that patients consent for evaluations, even if it's part of a quality improvement project. There was a really interesting article in the New England Journal from David Ash this past month about that, and the sort of challenges that we've sort of put upon ourselves by doing those kinds of things. And then we've also, tried implementing in a primary care high-risk setting, and we included clinicians evaluated the program because of feasibility aspects, but not patient evaluation. And we were able to get that primary care trial through the IRB without having patients consent. And so sometimes when you're figuring these things out, it just depends on your specific setting. There is a question here, you know, if you're doing workflows based on discipline, I would definitely agree that your workflow in a nursing home versus people who see, you know, patients for rehab short-term, I think you're going to have very different workflows, so I would definitely recommend doing separate. You may be able to do them in the same session, and maybe some parts of the workflow are the same, but some parts are different, and so I would definitely recommend looking at that. So here's an example of an adapted serious illness workflow. So we have a list of patients who are at high risk of death, so we came up with an algorithm, and then the MD reviews that list. So in a sense, you know, secondarily asking the surprise question. So we've narrowed it down, the list down for those patients. So then the MD decides whether that patient is appropriate or not. So you can see that the decision point is marked by a diamond, and they say yes. So then that person is added to a list to have the admin to add it to a list, and then the clinician then participates in the conversation, and then the patient, again, you have to make sure that the patient agrees to it, so another decision point. And if they say no, you want to mark down why they declined. If yes, then they go, you go through the conversation with them, the patient, or you send the pre-visit letter, and then the admin will block that time on the calendar. Then the admin gives the conversation guide to the clinician, and the clinician either has the consent to evaluate it, as you can see the yes arrow going down, and they have the conversation and they document it, and then the data manager is able to put that into their the database, or no, and then you document why, and then needs to be rescheduled at another point.
So as Rachelle's going through the example, what I'm noticing is that this example has a lot of evaluation components to it, and that's why you see this one is more complex than the generic example. So because they wanted a patient evaluation component and didn't do it just strictly as quality improvement, they consented the patients, had a data manager involved, collected quality data, or that patient evaluation data. You can collect patient evaluation data as quality improvement too, but here they chose to do it as a more research-based study. So you see, as you add on more questions to it, the workflow can get more complicated.
So there's some really good questions here. We have so many different sites with different resources. It's hard to imagine going to every site to create a workflow. How do you balance the situation? My recommendation for that would be to go to at least 3 different types of sites and go through the workflow process there. Then you could offer, you know, general lessons learned to each site or each type of site, and then you could also make suggestions to go through their own workflow. But I think I would definitely go through at least a few of them to figure out where your pain points are and how you could potentially work on those.
And actually, this example that's on the screen was implemented across a number of sites, almost 10. But what they did is they created this generic workflow and then went to the sites to talk about to the individual clinicians and staff members to see how it would work. But it needed to be adapted for each of those clinics as well.
Yep, great. So one other question is, do you see a connection between the serious illness conversation and created advanced directives? So I see the serious illness conversation as a first step of, and what I think you mean by advanced directives is more of formal documentation, either through, you know, something like a POLST or MOLST form. But I think the serious, what we see is the serious illness conversation is the first step of doing something like creating an advanced directive. Okay. So for the ICMP workflow template, so we had a group of high-risk care management nurses who already keep very careful track of patients and have their own workflows. So in a sense, when we implemented in this group, we saw them as a resource where their goals would really align with our program. So our central team would send a list of patients to the nurse with their upcoming appointment dates for those patients. So the nurse then would look at the list, would highlight the appointments that had that week, and then they could talk with their PCPs and sort of give them, and they may individualize it per PCP and say, this person I know they want to know in advance, and this person I can just tell them on that day. So the PCP then has the conversation with or without the nurse, and if the patient and then for the decision point there is that the nurse gets the notes from the conversation or is present, and then the nurse may help the PCP document and put it in the documentation module. Then the PCP will approve that documentation. Then the nurse will edit it based on the PCP's input, and then you have a documented conversation.
So we see lots of questions coming in, and that's fantastic. So we'd like to keep the discussion going. And so if you want to continue to put your questions in that chat box, you can also do the raise the hand, and we can open up your line, or you can use the Q&A box. So, that's a great question. So ICMP stands for Integrated Care Management Program, and it's that one was at the Brigham and Women's Hospital in our primary care center.
And those are nurses who are who typically have a fair amount of clinical experience first, but then yes, are trained care coordinators. So they're nurse care coordinators. That group just happens to be a pretty experienced group of nurses. The program also has resource specialists, has some social work staff, and also for a couple of pharmacists. So it's a group of people, but the workflow we showed was was really in the nurse care coordinator realm. It was an example from one clinic, one nurse.
So just to go back and clarify what the difference between the two decision points are. In the case of ICMP, or of the program that Josh talked about, what we saw is the first decision point was that the physician has a conversation and maybe takes notes. And as the program evolved, we saw that the nurses, as Rachelle said, were either in the conversations as well and took notes and documented the conversation, or sometimes the clinician would give the conversation or give the nurses their notes. And so the question is, did the conversation happen? And if it didn't, it should go back onto the biweekly list. If it did, oftentimes the nurse would draft the documentation of the conversation. And then the question becomes, did the physician approve the documentation so that it's available to all other clinicians?
There is a question here, and I'm not sure entirely what it's asking, but it's asking about patient identification through an EHR would be beneficial, at least to generate a list for the clinician to go through. However, the patient coding would need to be specifically focused to drive towards this usage. So I think the question might be about labeling this list and the fear of labeling this as a, I would not necessarily label this list as, would you be surprised if this patient died in the next year? Certainly patients can see these lists. So, I think using a more generic term like serious illness conversation list is certainly, acceptable for clinicians to see as well as patients. But I think that's what that question is asking.
There's another question, maybe Rachelle, you can jump in on this. So for workflows, from primary care compared to cardiology and oncology, for example, we mentioned each may need different workflows. Would you think that patient identification needs to change as well, is the first part, and then also if implementing across multiple specialties, how do you recommend attributing patients to non-PCP?
Great question. So I would say patient identification really definitely needs to change for cardiology versus primary care. It's actually probably a little bit easier in cardiology than in primary care because it's a more homogeneous patient population, but I think we'll save that question and the different kinds of, I mean, there's different algorithms that you would use in cardiology that are helpful. There's not as many in primary care, but we'll save that for the next webinar. But that second question about if you're implementing across multiple specialties, how do you attribute patients to non-PCPs? This is a great question, and I feel like we certainly haven't done this, but it would be wonderful if in your EMR you could either assign or allow clinicians to assign themselves to having these conversations, because I think it's different for different patients. Some patients feel really connected to their PCP. Some patients feel really connected to their oncologist, and there obviously needs to be communication between the two. But I think that there may be preferences both on the patient side and the clinician side, and we need to have, especially if we're working towards more accountability, we need to have a way within our electronic medical record system to capture this. And currently, I haven't seen, I would be curious to hear if there's anyone on the line that has a way to do this, because I think it's a huge need.
Yep. Just to add to that, which isn't going to make it any easier, but the literature that we have around this in terms of what patients want and what clinician wants varies dramatically. So when people have gone out and done interview studies of both clinicians and patients, what they find is that preferences are not consistent for anybody, which doesn't make this particular challenge any easier. One way is to let the patient be the arbiter, which is to say the patient can choose. Another way, as you kind of brought up in this question, is to let your workflows or your systems choose and then trust your clinicians if it's a patient that's not right for them, that they will, that maybe there's a separate workflow for how that then flows to cardiology or primary care or vice versa. So you can make choices around this in workflows, both in giving the patient a choice or in giving the clinician a choice, but it's not an easy one to answer. There's not a clear answer for a lot of patients. The short answer is a number of clinicians could do it, but the default in the system is that everyone kind of says someone else will do it, and so it doesn't happen.
That's good. I was going to have you guys either of you answer this question based on your experience maybe in primary care or in the inpatient setting. And that's, what success have you had in using nurses or maybe even other types of clinicians in all settings to have serious illness conversations? He states that the MDs in some cases don't adequately prioritize these conversations.
So I think that's a great question, and it actually ties into what we were talking about previously. I think you need to, at some point, have some accountability, or everyone's pointing their finger the other direction. So in our ICMP group, we did, the nurses had some accountability for their patients to have conversations. However, they weren't expected to do them alone, and they were expected to prompt their PCP partners to have conversations. Now, obviously, that's not going to go well all the time, and that's one of the reasons why it's really important to have someone who's charged with supporting the nurses and to sort of act as a go-between for those difficult clinicians. So sometimes it can be another nurse that can support that nurse to have the conversation. Sometimes it can be a physician that reaches out to that resistant clinician and says, hey, you know, what's going on? And, you know, sometimes it can be something as easy as this patient is really one of their favorite patients, and they just can't, you know, they're emotionally having challenges. Or it might be something as difficult as this patient has a really complicated family situation, and there's multiple people involved already, and, you know, that they may not want another person involved. So I think it just depends, but I think having the resources to reach out to support our nurses, both from a nursing standpoint and a physician standpoint and social work, is really important.
And I think just to add to that, that's for I agree wholeheartedly with that the conversation itself, with how you're thinking about that or talking about it. The other point to make is I don't think I've ever seen an entire workflow from start to finish without involvement of multiple people. So no matter what, whether it's, and it varies from clinician to clinician who's sitting and actually have the conversation, but from a larger workflow standpoint, nurses, office staff, will need to be involved to make this function. Yeah.
Yeah.
But it's a great point. And yeah, people, and as Rachelle pointed out, our experiences, people have done it very differently, and it varies from clinician to clinician and patient to patient, and they strategize some, and sometimes it just depends on who's available.
So someone is saying here, and please feel free to type back in if I don't get this right, but in oncology, it's important to have parallel, distinct pathways. I think that might mean the pathways between nurses and physicians, but I might be wrong. It says most patients and our oncologists are not comfortable discussing failure. He's suggesting it might also be true of cardiology. So I'm guessing what you're saying is having pathways for nurses, like a workflow for nurses, maybe in a nurse workflow. No, Josh, you think it might be?
I think we're not.
Yeah, could you clarify that? The other pathway, I mean, the other thing I could think about is kind of setting up the best case, worst case scenario, or first line, second line kind of concept. Maybe that's the pathways we're talking about, because if one is considered a failure, it's either we succeed or fail. That's a tough pathway to talk about from a conversation standpoint.
We can.
But you can jump in on that.
Other people have.
There's also a Crystal Care was said they were trying to do this from a system standpoint, so it would be interesting to hear what they're doing.
Oh, I see.
What was the?
So the pathway is either via oncologist or via a nurse or palliative care provider. And there is some data to suggest this too, Rachelle. You can jump in here as well. But some patients have voiced that they expect their oncologist to be the person who is the positive voice and the person pushing for treatment and managing treatment, and they may not want to have this conversation, as you point out, of failure of oncology treatment with their oncologist, but they may be looking for someone else, be it a nurse or a palliative care provider or their primary care provider, to have that discussion. So that's a great point. So and it kind of comes back to the clinician selection part of patient selection, which is for an individual patient, and tell me if this isn't what you're getting at, but it may be that for an individual patient with a particular oncologist, that they may say the patient may prefer to have that conversation with a different provider, be it a nurse, a palliative care person, someone who is neutral from their oncologist who is making decisions about chemotherapy. Yeah, I see your point. It may be true in cardiology too, especially around advanced therapies like that and transplant and stuff like that.
Thank you.
Did we get that right?
John, you can let us know if we got it right.
Yeah.
If anyone else who has examples or experience of their workflow, you got it right, Josh.
Yeah.
Their own experiences, whether it's difficult or if it went well for you, we'd love to hear. As we wait for that, we can move to our take-home messages, which are really, workflows are important. They're part of successful implementation, which we heard from both Josh and Rachelle. It could be easier to start with a generic workflow. We talked about analyzing your current workflow as well, but especially if you're going into a lot of different smaller settings and have a lot of different clinics, starting with a generic workflow and adapting can be helpful. And then really that thing that I think we talk about on every single webinar now, engagement is key from frontline staff, your administrators, your receptionists, nurses, and the physicians. So again, you can feel free to ask more questions. We're going to open up our last poll. We'd love to hear from you just on whether, whether this webinar was helpful and met your needs. And then if it didn't meet your needs, or if you have anything else to say, you can really use this as a comment section. What did we miss? This is an open, I'm going to open it now for you, but this is an open answer response. So you should be able to type your answer right below. We'll give you about 3 minutes to answer this. So we have a minute left on this poll. If you've started to fill it out, you just need to click the submit button when you're done.
And as you guys finish up, just one more take-home point that is just very clear from a lot of what you all are writing, which is you guys are focusing on, or all of you are asking questions and bringing up really important points about particular challenges that go with this work, such as patient identification, clinician identification for how you're going to choose who's going to have the conversation with which patient, also strategizing about the conversation itself, which clinician is in the room and how did they set up the appointment. Just one point to make, since we are on the workflows part of this webinar piece of things, is it's also very, very valuable to step back and look at the process around that, if not really important, if not possibly even more important. I have made this mistake myself where I spent a ton of time working on the conversation itself, launched it in a particular space or with a particular clinician, and then nothing happened for 6 months. And then I went back and tried to figure out why, and it's because I hadn't done the workflow, so no one was setting up an appointment. So they were good and ready to have the conversation. They knew who was going to do it. They were all ready. But kind of to the point of the workflow piece of this is mapping out all the individual steps from start to finish. Well, it can be challenging and maybe even tedious at some point, has a really important point or has a really important part in this work for making sure you get the outcomes that you're looking for. Because focusing on one step when there's steps missing can lead to a fair amount of frustration or not much movement.
Thanks, Josh. Oh, there's the full functionality. So I also want to let you know, because we got a few questions about this, is all of these webinars are available on the community of practice. It takes about a week for them to get uploaded. And so the video is there. You can view it anytime, and the slides will also be available on the community of practice website. Our next webinar is December 14th, so actually just a few weeks away before a winter break. And that one is about adapting the guide to different settings. And so that, again, you remember we are having that patient identification, since there was a lot of questions on that today. That one will be on Tuesday, January 23rd. And again, Josh will be here to help present on that. So again, we really would just like to thank you all for attending today. We truly appreciate it. We loved the interactiveness of this webinar. It was great, and we wish you all well for the rest of your day.
Thank you, everybody.
Thank you.
Thanks, guys.